So today we are going to cover half of chapter 15. We're going to talk about the heart. The next lecture is going to talk about the blood vessels. So first of all, the heart pumps about 7,000 liters of blood through your body every day. It contracts about 2.5 billion times in your lifetime, which is quite a bit if you think about it. So the heart does a lot of work. It's going to pump the blood all throughout your body. So it's going to go through the arteries and then through the arterioles, to the capillaries where gas exchange is going to occur, then to the venules, the veins, and finally back to the heart. The heart and all the blood vessels together make up the cardiovascular system. And circulation is really important because you have to get nutrients to your tissues and you have to get rid of waste products. Oxygen, of course, needs to get to your tissues and you have to get rid of carbon dioxide. So it's really important that your cardiovascular system is functioning properly. Cardiovascular itself refers to both the heart and the blood vessels. So the heart is the pump. The blood vessels are like the highway, so that's where the blood travels through. There's two circuits, the pulmonary circuit and the systemic circuit. Anytime you hear pulmonary, you should think of lungs. So the pulmonary circuit is going to transport oxygen-poor blood from the heart to the lungs and then back to the heart. While it's in the lungs, the blood is going to pick up oxygen and drop off carbon dioxide. Systemic circulation is the other half. It's going to transport that oxygen-rich blood from the heart to all of the cells in our body and then back to the heart. So the blood is going to deliver those nutrients to the cells and get rid of all of the waste. This is just showing you the heart and circulation. So the left side of the heart is always going to contain oxygen-rich blood. The right side of the heart is always going to contain oxygen-poor blood. So again, it's going to run through the pulmonary circuit, which includes the lungs, and then the systemic circuit, which goes to the body. The heart itself is hollow, it's cone-shaped, and it's very muscular. It's a pump. It's in the mediastinum of the thoracic cavity, right on top of the diaphragm, and it has 4 chambers, 2 on top, 2 on bottom. The 2 on top are the atria, and the 2 on the bottom are the ventricles. And the ventricles are where it gets most of the pumping action. The heart size is going to vary with your body size. They always say it's about the size of your fist. Average, it's about 14 centimeters long and 9 centimeters wide. Again, it's in the mediastinum, so it's going to be posterior to the sternum, medial to the lungs, and anterior to the vertebral column. The base lies right beneath the second rib, and the apex is at the 5th intercostal space. And you can see the picture of a heart right there. This is just showing you the location in the body. So again, the mediastinum. The heart has some covering, so the pericardium covers the heart and the larger blood vessels. The fibrous pericardium is the outer layer, and that's going to surround a double-layered serous membrane. So the fibrous pericardium is basically a loose-fitting sac that encloses the heart. The double-layered serous membrane that it surrounds also has 2 layers. The parietal layer and the visceral layer. So the parietal pericardium is deep to the fibrous pericardium, and it's the outer layer of the serous membrane. The visceral pericardium is the inner layer of the serous membrane, and that's going to be attached right to the surface of the heart. It's also referred to as the epicardium. So there are 3 distinct layers in the heart. The epicardium is that outer layer, again, also called the visceral pericardium. It's very thin. The myocardium is the bulk of the heart. This is the middle layer, and this is composed of cardiac muscle tissue. And then the endocardium is a very thin inner lining of all of the heart chambers. And again, it's going to layer those chambers, but it's very thin. So if you dissect a heart, it's not like something you're going to be able to peel back. It's so thin, it's very delicate. This is just showing you the different layers, what they're made up of, and the function. So that endocardium is epithelial tissue, and it's going to form that protective layer on the inside of the heart. As I said, the heart's divided into 4 chambers, 2 atria on top, 2 ventricles on bottom. The atria are very thin-walled chambers, and they receive blood that's returning to the heart. They have auricles, which are little flap-like projections that extend from the atria, and these are going to allow the atria to expand. The ventricles are very thick-walled, and those are the lower chambers. Those are your pumping chambers. So the right atrium receives blood returning from the systemic circuit, from both the inferior and superior vena cava, and the coronary sinus from the cardiac circulation. It's going to pump the blood to the right ventricle. The right ventricle receives the blood from the right atrium and then pumps it to the lungs. The left atrium receives blood from the pulmonary veins and pumps it to the left ventricle. The left ventricle is going to get that blood and pump it to systemic circulation. So the left ventricle is the most muscular of the four chambers. It has to pump the blood to the systemic circulation, which, as you can imagine, is quite a distance. So it has to have the most force to pump that blood out. These are showing you the valves. Make sure you know their locations and their functions. So the tricuspid valve is also known as the right AV valve or the right atrioventricular valve. That name kind of tells you where it is. It's between the right atria and the right ventricle. And it's going to prevent blood from moving from the right ventricle back into the right atrium when the ventricle contracts. The pulmonary valve is the entrance to the pulmonary trunk. That's going to prevent blood from moving from the pulmonary trunk back into the right ventricle when it relaxes. The mitral valve is also known as the left AV valve. This is going to prevent blood from moving from the left ventricle back into the left atrium when the ventricle contracts. And then the aortic valve is the entrance to the aorta. That's going to prevent backflow of blood from the aorta into the left ventricle. So all four of these valves are basically going to prevent backflow. Once the blood is pumped out to wherever it's going, you don't want it coming back. So once the blood leaves the atria to get to the ventricle, you don't want it to go back when those ventricles contract. So picture showing you the valves in the inside of the heart, an actual heart. The top left is showing you that tricuspid valve. The top right is the bicuspid valve. In the center, you have the aortic valve, and on the bottom, you have the pulmonary valve. Now, these valves also work in different ways. The tricuspid valve and the mitral valve actually have what are called chordae tendineae. Those are also referred to as the heartstrings. So those are attached to papillary muscles, and they're going to contract to close. The aortic and the pulmonary valves, on the other hand, the blood fills up the cusps, and that's going to prevent it from opening, the pressure from the blood in there. There's rings of dense connective tissue that surround the pulmonary trunk and the aorta. They provide attachments for those heart valves and the muscle fibers. Again, it's going to prevent excess dilation of the heart chambers during contraction, and we don't want backflow. Those rings and other fibrous masses in the interventricular septum are the skeleton of the heart. And the interventricular septum tells you where it is. It's between the ventricles. This is showing you blood flow through the heart. So, if we start with the systemic circuit, we have blood going to the vena cava and the coronary sinus. It's going to dump the blood into the right atrium. It's going to go through the tricuspid valve or right AV valve to the right ventricle. Then it's going to be pumped through the pulmonary valve to the pulmonary trunk, through the pulmonary arteries to the lungs. The capillaries in the lungs are going to exchange gases. So we're going to drop off carbon dioxide and pick up oxygen. The pulmonary veins are going to take it back to the heart, to the left atrium, where it will go through the mitral valve or the bicuspid valve, also known as the left AV valve, to the left ventricle, out the aorta or aortic valve to the aorta, which is going to push it to the systemic circulation. The cardiac supply, the coronary supply, the heart has to have its own supply, basically. So the left and the right coronary arteries are going to supply blood to the tissues of the heart. These are the first two branches of the aorta. So basically, the heart does not use the blood it pumps. It actually has its own circulation. And this is just showing you the blood supply to the heart. And a picture. The cardiac cycle is what takes place during a heartbeat. So the chambers have to function in a coordinated manner. The heart is going to be regulated so that the atria contract, which is known as atrial systole, while the ventricles relax, which is known as ventricular diastole. Then the ventricles are going to contract, which is ventricular systole, while the atria relax, which is atrial diastole. So we want the atria to contract while the ventricles relax, and then we want the ventricles to contract while the atria relax. You don't want them contracting at the same time. You don't want like the left side contracting and the right side contracting. We basically want the top of the heart contracting and then the bottom of the heart contracting. Some science. We have to sometimes replace the heart. They are doing many things with transplantations, including stem cell technology. So a heart transplant, of course, is a replacement of a failing heart with a donor heart. You could have an LVAD, which is a left ventricular assist device. It's basically a mechanical half heart that will be used until a donor heart's available. An implantable replacement heart is a titanium and plastic artificial heart. These are used in people that can't have a heart transplant, but keep in mind they don't have long to live. This isn't a permanent solution for somebody who's young. They're not going to live to be old. And then stem cell technology. We have cardiac muscle tissue that can actually now be cultured from some altered somatic cells or stem cells. This may actually allow some little patches in the future to where you can repair damage, which is kind of cool. So during a cardiac cycle, the pressure in the heart chambers is going to rise and fall. During atrial systole, which is when the atria are contracting, and ventricular diastole, the ventricles are relaxed, the AV valves are open, and the semilunar valves are closed. The semilunar valves are talking about the pulmonary valve and the aortic valve. About 70% of blood actually flows passively from the atria into the ventricles. And then that last atrial systole contraction pushes the last bit of blood into the ventricles. That's going to cause ventricular pressure to increase. So this is one reason why people who have an atrial fibrillation can actually survive, because most of the blood just flows from gravity passively down from the atria into the ventricles. So that's why ventricular fibrillation is so much more dangerous than atrial fibrillation. So during ventricular systole, which is contraction, and atrial diastole, the AV valves close. Those chordae tendineae prevent the cusp of the valve from bulging too far backwards into the atria. The atria relax, and blood flows into the atria from the vena cava and pulmonary veins. The ventricular pressure is going to increase, which will open the semilunar valves, and then the blood will flow into the pulmonary trunk and the aorta. Heart sounds that you hear with a stethoscope are because of the closing of those heart valves. The vibrations are associated with that sudden slowing of blood flow. So the lub is the first heart sound that occurs when the ventricles are contracting. So this is the AV valves closing. The dup sound is the second heart sound, and that occurs when the ventricles are relaxing. So the pulmonary and aortic semilunar valves are closing. If you have a heart murmur, it's an abnormal heart sound because your cusps are not closing all the way on the valves. Now this could be anything from mild to serious. Again, this is just showing you where those valves are at. So cardiac muscle cells branch, we know that. Intercalated discs between the cells have gap junctions, those are the communicating junctions, remember. So action potentials can spread through a network of cells. Cardiac muscle fibers form a functional syncytium. Now that word I've heard pronounced multiple ways. I've heard syncytium, I've heard syncytium, so, whatever you want. Basically, all it means is it functions as a unit. So in the atrial walls, it's going to be called atrial syncytium. and the ventricular walls, it's ventricular syncytium. So the cardiac conduction system is basically clumps and strands of specialized cardiac muscle that are going to, first off, initiate the impulse, but then spread it through the myocardium. So the SA node is the senoatrial node. That's the pacemaker of the heart. That's going to control atrial syncytium. Junctional fibers are then going to transfer to the AV node, which is the atrioventricular node, through the AV bundle to the bundle branches, through the Purkinje fibers, which will then cause ventricular syncytium. So basically, the SA node is going to spread the impulse across the atria, and then it's going to travel down the AV bundle, which is the atrioventricular bundle, up the Purkinje fibers, which will then cause ventricular syncytium. So as I said, the SA node, or the senoatrial node, is the pacemaker, so that's going to initiate the rhythmic contractions. We have internodal atrial muscle that's going to conduct the impulses across the atria. The junctional fibers are going to conduct the impulse from the SA node to the AV node. The AV node, the atrioventricular node, as I said, conducts the impulses to the AV bundle. Here it's delayed a minute. Not a minute, but, delayed fractions of a second. It's very important that it's delayed, though, because the atria have to finish contracting before the ventricles contract. The ventricles are so much stronger than the atria. If they don't finish contracting first and the ventricles contract, we're going to have massive backflow. So that delay is called the nodal delay, and it's very important. Then it goes to the AV bundle, also called the bundle of His. That conducts the impulses pretty rapidly between the SA node and those bundle branches, which there's a left and a right. They conduct the impulses to the Purkinje fibers, which then go to the ventricles and cause the ventricles to contract. So here's a picture showing you the major components. An EKG is going to record these electrical changes that occur. It's used to assess your ability to conduct these impulses. So when you look at an EKG or an ECG, you're going to have a few different things you're looking at. The P wave is caused when the atria depolarize. That's going to occur right before they contract. The QRS complex is ventricular depolarization, and that occurs right before they contract. And then the T wave is ventricular repolarization. That occurs right before the ventricles relax. Now, the atria are also going to be contracting, but the ventricles overpower them, so we don't really see them as far as the wave goes. So the QRS complex is all the ventricles. This is just showing you an EKG. So you have the P wave, and then the QRS complex is the big jump, and then the T wave is right after it. This is putting together the pressures, the blood volume, an EKG, and your heart sounds to compare them all together. The SA node normally controls the heart rate, so as I said, this is the pacemaker. Sympathetic and parasympathetic fibers are going to modify your heart rate in response to anything that changes. So if you're exercising, if your body temperature goes up or down, if the fight or flight mechanism's kicking in, or your calcium or potassium ions are fluctuating. Parasympathetic impulses through the vagus nerve are going to decrease our heart rate. This is going to have influence on both the SA and the AV nodes. So it's going to slow it down. It's going to slow those impulses down. Sympathetic impulses are going to increase our heart rate. So it's going to accelerate the SA and AV nodes and the ventricular contraction. Baroreceptor reflexes are going to come from the cardiac control center in the medulla oblongata. This is going to balance any inhibitory and excitatory effects of the parasympathetic and sympathetic fibers. So the cardiac control center is going to regulate the autonomic impulses to the heart in a nutshell. This is just showing you the general reflex arc and how the autonomic impulses alter the heart's action. Arrhythmias are any kind of heart rhythm altered. There are several types. Fibrillation, I've talked about this already, but that's an uncoordinated chaotic contraction where you have small areas of myocardium just contracting. As I said earlier, atrial fibrillation is not life-threatening, but ventricular fibrillation is often fatal. Atrial fibrillation, if you have some chaotic contraction going on, most of the blood falls down to the ventricles on its own. So that's why it's not life-threatening. Tachycardia is an abnormally fast heartbeat, so anything greater than 100 beats per minute when you're at rest. Bradycardia is an abnormally slow heartbeat, so anything less than 60 beats per minute when you're at rest. A flutter is a rapid, regular contraction of the heart, anywhere from 250 to 350 beats per minute. Usually doesn't last long. A premature beat is a beat that occurs before it's expected in the normal cardiac cycle. Sometimes it's going to originate from an ectopic region that's not the SA node. If you have damage to the SA node, the AV node can actually take over and act as a secondary pacemaker. But your heart rate's going to slow down from 70 to 80 beats per minute to about 40 to 60. And that's called an ectopic pacemaker. An artificial pacemaker is when you have to have a device implanted that's battery powered to kind of shock your system into acting right.